Sure. So I will be presented the minimal residual disease analysis from the phase 3 randomized PERSEUS trial. So briefly, just to put in context, so PERSEUS is a randomized phase 3 study that is comparing Daratumumab in combination with VRD, induction, transplant, and consolidation, followed by DR maintenance, so Daratumumab lenalidomide maintenance, versus the standard VRD induction, followed by transplant, followed by consolidation, and lenalidomide maintenance. So the primary results of this trial were presented at ASH last year. And in summary, DVRD resulted in a significant improvement in progression-free survival over VRD, and also an increase in the depth of response, or a higher proportion of complete response, a higher proportion of minimal residual disease negativity, and we are presenting more results about the maintenance phase and a minimal residual disease analysis. So the key takeaways of the presentation are that DVRD induction consolidation followed by DR maintenance significantly increase the proportion of patients achieving minimal residual disease negativity, both at 10 to the minus 5 and 10 to the minus 6. So there is a deepening on the responses across the treatment and more profound during the maintenance part, and this deepening of the responses occurs more frequently in the Daratumumab arm as compared to the standard arm. So when we go for the subgroup analysis for MRD 10 to the minus 5 or 10 to the minus 6, we do see a significant benefit for Daratumumab plus VRD followed by DR maintenance across all pre-specified subgroups, including patients with older age, patients with ISS3 or high-risk disease, both 10 to the minus 5 and also in 10 to the minus 6 threshold. If we speak about sustained MRD negativity, at least 1 year or more, or 18 months or more, we do see again a higher proportion of patients in the DVRD plus DR arm achieving sustained MRD negativity, both 10 to the minus 5 and 10 to the minus 6, as compared to the VRD regime. And again, in the subgroup analysis, there is a benefit across all pre-specified subgroups, including, again, older age, high-risk disease, ISS stage 3. So if we analyze patients that were defined as having high-risk cytogenetic abnormalities, in this study, the definition was either patients with deletion 17p, 414, or 1416, we do see the same. So patients that were allocated to the experimental arm, DVRD plus DR, they had a higher rate of MRD negativity, both 10 to the minus 5, and most importantly for high-risk patients, also in the deepest level, so 10 to the minus 6, and also a higher proportion that were able to sustain MRD negativity in the DVRD arm versus the VRD arm, and this translated into a benefit in progression-free survival. Another aspect that I found is very relevant for this study and speaks about the importance of continuing on therapy is that the proportion of patients that were able to convert from MRD positivity at the end of consolidation to MRD negativity or sustain MRD negativity during maintenance was higher in the DVRD arm as compared to the VRD arm. So I think all this data overall reinforce this treatment, DVRD induction consolidation followed by DR maintenance, as the newest standard for transplant-eligible newly diagnosed myeloma patients. So the impact is that we have a new standard of care. So and the biggest impact I will say is that we will have probably a new maintenance therapy, to be proposed to our patients, really aiming for these, very deep responses.